Hello everyone, this is Alraies from CVI 2023. I'm really privileged today to be with Dr. Vijay Iyer. He is the Chief of Cardiology at University of Buffalo. Vijay, thanks for being with us.
Thank you for having me.
So we're going to talk about a very unique topic. We see it more often now, physicians as leaders or physician as service line builders. So you are Chief of Cardiology, and I'm assuming when you went to this role, you had a lot of challenges, and also you have a team that you built together to come up with the service that you put together now. Can you walk us through the process and the challenges?
Right. I think if you look at most cardiovascular administrators or different service lines across the country, there are two different models. One is the pure academic model, where it's a university-based system. The entire hospital is owned by the university, so the chief of cardiology also sort of functions as the service line leader. Then there are other systems where the university may be separate from the hospital, or the hospital may be unaffiliated with the university. So you may have an administrator who may or may not be a physician runs the service line. So we have a unique situation where the hospital is not owned by the university, but the university works in the hospital. So we have sort of a separation between the two. So I have the unique privilege of being service line leader for the hospital system, but also chief of cardiology for the university. And I think in some ways that is important, and I think when I took on this role, the second role, the chief of the service line, was not mine. But I think over time, everybody realized that that's an important component of what we do. In terms of building these kinds of relationships, it's important to recognize the lay of the land, right? Every university, every hospital system, every hospital individually is different in how it functions, how it's structured. Every place is a little bit different. In some places, cardiac surgery is a standalone institution. In some places, cardiac surgery works with cardiology. In some places, cardiac surgery is with surgery. So every place has a different flavor, and you have to sort of recognize what that team should look like. For me, looking at our institution when I started, to me it was clear that we needed to function cardiology and cardiovascular surgery together. I actually think vascular surgery is part of that mix, and we are still in the process of trying to integrate that to some extent. The growth of an institution, when you look at it broadly, there are three things that you have to focus on. One is the actual patient care component, which to most hospital administrators is the most important component, because that's what generates revenues, that's what generates your hospital reputation. The second part of it, which is more the academic mission, the university is more interested in the academic mission, which is the teaching of the residents, the fellows, the medical students. And then
grant and research.
Those are three. And where as a service line leader or as a chief, you have to balance the three out. And sometimes it can be a bit of a challenge, because you may feel yourself pulled in different directions. So you've got to create and set expectations for both the hospital system and for the university. Try to make them see the value in all three and how one enhances the other.
Yeah, I just want to pause here for a second. So when you sign up for these roles, do you understand, or is it your interest to say what's the lay of the land before you sign up, so you can make sure you can execute on this?
I think it's critically important to understand the lay of the land before you take on these jobs, because some situations, there may be an expectation of the leadership of what you can do, and it may be completely unachievable because of how it is structured. For example, if you are brought in to be the chief of a service line where cardiac surgery works completely independent of you, but the expectation is that you are somehow going to enhance cardiac surgical volume, it is not going to work. So you have to sort of understand the lay of the land. You have to know where you have people who can help you and where people cannot help you. And like anywhere else, you walk into any situation, you want to understand where the pitfalls are before you walk into it. They may be surmountable, but some places you may want to not take on those roles because you're destined for failure, and you have to recognize that relatively quickly.
This is a very critical point. As you know, we get excited, we're getting a new role, and maybe there is kind of improving your career, but maybe it's a setup for plateauing.
And I think you also have to decide where you are in your career before you take on a position like that.
What is the perfect time?
I don't know that there's any perfect time, and I think that's the critical part. I took on leadership roles very early in my career, and I'm not necessarily sure that it was probably the right thing for me to do at that point, because I was still building my clinical practice. So the demands on your time can be quite considerable when you're trying to build a clinical practice and you're trying to build an administrative service line. So I think you have to be careful as to what stage in your career you're willing to do it and what you're willing to give up to do it. Because you often do have to give up something to be able to do those administrative responsibilities. And that oftentimes means giving up mostly your clinical time, because that is what takes up most of your resources in your time, which means that if you're a little bit more advanced in your clinical career, where you feel like there are opportunities for you to delegate your responsibilities to some extent. Being a good administrator is not easy. There are many aspects of the business that you have to understand. There are many aspects of interpersonal relationships that you have to develop. And you may have to develop your own skills in those fields. And it may not be something that you're born with. And you have to work at it just like you work on building your catheter skills or learning how to do an EP procedure. It is a skill that you have to develop. And you have to be, you really have to have a self-awareness of what skills you lack and what skills you really bring to the table.
And you're mentioning a very important point about the relationship, especially with the administration. Sometimes their lifespan, their career time during that institution way shorter than as us as physicians.
Yes, and I think that's a critical component for both sides to remember. I think the average lifespan of most CMOs and CEOs in healthcare systems is 3 to 4 years. Most clinicians practice for 20 to 30 years, you know. So in taking on those responsibilities, I think you have to be cognizant of what you're doing and how you are potentially damaging relationships with your clinical colleagues by doing maybe the administration's bidding. So you ought to be careful about what you're doing. At the end of the day, if you're in an organization that supports physicians and clinicians, which really should be the case, you have to make decisions that bring your team along with you. And that team means both physicians and the administrators. You have to bring them along with you in the sense of building consensus.
It's not a fight, it's collaboration.
Exactly. At the end of the day, if we all recognize that we want the same thing, right? We want our institutions to be successful. We want our individual physicians to be not just successful financially, but well satisfied in their lives and their careers.
So which
is a very important component of, you know, all this talk about burnout and all of that comes because we as an organization, not just we, but in general organizations haven't paid attention to physician well-being or provider well-being.
And that's your job as a leader.
It is as important as building RVUs. In fact, I often discourage younger individuals from taking on too many clinical responsibilities because there's an eagerness when you're young to do more and do more, not recognizing that the toll it takes on your personal life or your interpersonal relationships. I think as a leader, as a chief of the division, as a fellowship director, that's one of the first things I tell people. You have to watch what, and as they say, as your plate gets loaded, you got to figure out what's dropping off from that plate.
Yeah, so Vijay, as you said, it's very critical because you carry too many hats and too many responsibilities. And as a busy clinician, it's the hardest for you to let go of the clinical aspect. You have to balance your clinical work as well as give it away to somebody who can deliver the care that you are looking for.
Exactly. I think those are critical components of building key service lines and being a leader.
Last question is a physician required or is recommended to have an MBA for such roles?
I don't necessarily think that it is a critical component. In carefully crafted dyad leadership patterns, where you have an administrator and a physician leading a service line, the physician needs to have a reasonable understanding of the business components of it. The dyad person, the administrator needs to have a reasonable understanding of the clinical end. But if they can be compatible and if they can really synergize their energies together, I don't necessarily think that you need an MBA. Having an MBA probably helps, but I don't necessarily think that it is a key component to being successful.
Yeah. Dr. Iyer, thank you so much for your time and really very fruitful interview. You're the first one who talked about this topic, so thanks for taking the first stab at it. Thank you for watching, everyone. This is Chadi Alraies from Austin CVI 2023. Dr. Iyer, thank you so much.
Thank you so much.